Next week, Congress takes on an important issue of trying to repeal the health care law that was passed last March. The overarching message of why we needed health insurance reform and health care reform was to clearly reduce the cost and maintain the quality of health care delivery for every citizen of the United States. Nobody's ever going to argue with that message. What does need to be argued, however, is the means by which we put in place the execution of the law and the underlying math and logic behind how the law was going to be paid for. Before we simply look at repealing the law, it may be more credible for legislators next week to try and peel back the various layers of the law to understand the logic and how, in fact, perhaps certain provisions of the law could be incrementally implemented in order to actually save the country significant dollars, hundreds of millions of dollars, without incurring the same deficit, over $1 trillion, that we see today. The key reasons behind the repeal are ones that we hear every day in the media. It's the issue of the individual mandate, enforcing individuals to buy insurance coverage when in fact they can't be forced to buy other things by previous rulings. Is that constitutional? Well, we don't know yet. That will ultimately be the decision of the Supreme Court as they review the pending cases with 20 states that are still out there. The issue of rising insurance cost and the fact that even as of today, insurance carriers continue to raise their rates in states such as California is a major issue, and how that's going to be kept in check, the control that insurance commissioners can really have over the individual and self-insured markets is still yet to be determined. The access to physicians and the fact that many doctors are being tossed out of healthcare plans today, the fact that insurance carriers are narrowing their networks is a major problem. And the message on which the bill was passed last year was that we could keep our coverage, we could keep our doctors, but that isn't the case. And what we have to look at as a part of peeling back the law is why that isn't the case, why we're not able to keep our coverage, and why it's not that easy to keep our doctors. What is the ultimate impact of the deficit? I think the greatest concern, especially in the midst of an economy that is yet to recover, is the fact that some of the assumptions that have been baked into the new law in terms of how it's going to be paid for don't seem very credible. Are we going to be able to recover the dollars from Medicare, and who is going to be compromised from the proposed fraud and abuse that's within Medicare today, and how will we ever know? Today we're proposing that a lot of those savings are going to come from how we implement certain strategies, where yet in the same breath there are over 200 exemptions that have been provided for compliance with the new law that circumvent the ability for us to actually recognize those savings. So that the overall execution and the assumptions in terms of how we were going to derive those savings have been lost. There's a huge issue which is no longer really on the table with regards to the public option, but yet there is a significant concern in terms of how much control the government is going to have in terms of our health care and the decisions that are going to be made. We did see for a brief period last week that perhaps end-of-life decisions and some of those quote-unquote death panels were going to be reintroduced, but that doesn't seem to be the case right now. So what is the solution and what is the approach that legislators and congressmen ought to take next week as they peel back the law and maybe not necessarily repeal the law? Number one, maybe we should reappropriate the investment and the hundreds of millions of dollars that have been allocated to physicians and hospitals to implement electronic medical records and move those dollars into investment in infrastructure, meaning technology, to provide the necessary entities with transparency in terms of why insurance premiums are going up. We don't really have that infrastructure today, and we've put the cart before the horse in forcing doctors to implement systems and technology to provide data around medical care and quality, which is important, but that's much further down the road. The new law, in its 2,000 pages, really focuses on coverage and cost and how individuals are going to access the system, so that the data that we need right now is around that. There's very little that really addresses the quality of care and delivery, which comes later in the equation. So let's move some of those dollars and invest in the technology that we need to make that transparent. It's almost as if we were building a house and we were focused on building a jacuzzi in the master bedroom, but there's no foundation to the house, there's no electricity, there's no plumbing. The second element is mandating employers, plan sponsors, to implement technology just like we're forcing doctors to do that, and provide them with financial incentives that gets them the transparency and the grip hold to be able to hold insurance carriers accountable. Employers have really not been as aggressive as they need to, nor are they mandated to do so. If they're going to be in the business of providing health care for their workforce, then they too need to be held to task in terms of what's going to be required of them to be able to hold the insurance companies accountable. The insurance commissioners and Secretary Sebelius are trying, but the fact of the matter is that Secretary Sebelius and the insurance commissioners only have limited jurisdiction on the individual market, which is a small fraction. 70 to 80% of the market, which is self-insured, the insurance commissioners have no jurisdiction over. So they can pound and kick the table and try to force insurance companies to not raise rates. But there's very little that the insurance commissioners can really do at the end of the day other than review those rate increases, which is what's happening in California today. Subsidizing the states. We're hearing about the number of states that are on the verge of bankruptcy because they can't afford, they're not solvent to be able to sustain Medicaid. And similarly, subsidizing the states more than we have right now with the necessary funds to put in place the infrastructure around the health information exchanges, to fund the high-risk pools is really important. We haven't even put enough of a down payment for the high-risk pools, which is why the adoption has been so low. We have to have the insurance exchanges up and running in the next couple of years, and we have to relook at the investment that's necessary for us to be able to create solvency for the states, to be able to bear the burden of these health insurance exchanges and the high-risk pools and Medicaid in order for them to sustain part of this burden. Maybe it's time to put in place penalties for people that actually don't want to implement better lifestyle changes. We do that with car insurance. Somebody with a bad driving record is going to pay more for them to get car insurance than somebody who has a good driving record. And maybe it's time to put in place penalties for those who choose to not exercise or who choose to conduct a lifestyle that ends up costing all of us more in terms of overall health care expense. And it's time to maybe look at insurance as a measure of one's risk, where today that hasn't really been factored in. The provisions under the Rivlin-Ryan proposal, Congressman Paul Ryan has been very proactive in terms of looking at Medicare and how we could cap out-of-pocket expenses and really expect Medicare enrollees after a period of time to actually pay some of their small expenses up front is a possibility that perhaps creates greater solvency out of Medicare, which is a major concern. And those that are eligible for Medicare after a probation period would actually get vouchers that enable them to purchase services. But perhaps those vouchers are based upon the risk of the individual and a calculation that estimates how much is that individual with diabetes in the Medicare program and high blood pressure going to need to take care of themselves for the next 10 years. Part of the problem is that we have assumed that coverage and having coverage is a proxy for care. It's not. And there's this misnomer that by having insurance coverage, that's going to take care of everything. And the individual mandate and forcing people to buy coverage unless they know exactly what that coverage is going to cover is a detriment to the consumer, because we're asking them to buy something that may not have any inherent value. How do I know that that $1,500 policy is actually going to be able to cover the things that I'm going to need if I have diabetes? We don't know. So risk-based coverage, condition-based coverage is really important, especially as we're looking at the Medicare population and the management of chronic conditions. Similarly, for the allocation of what the states are going to get for creating solvency from Medicaid, every state has a different demographic. And looking at the underlying risk of the population and being able to estimate those allocations is going to be far more accurate than looking at the high-level assumptions that the CBO uses today in terms of actuarial estimates, based looking at life tables based on actual estimates. And that's a fundamental flaw that we have to reevaluate in terms of how we came up with the numbers and the assumptions that we're going to fund this deficit. Nobody believes those numbers. The CBO's numbers, I think, are as effervescent and as incredulous in terms of the best guesses. Now, it's perhaps the best that they have because that's all the data is that's available. But remember that an investment in the infrastructure and the technology that forces the insurance companies and other service providers to make that data available is going to be how we get to the bottom of this in terms of understanding why the increases are going up, what it really costs to deliver services, and how we can better negotiate. We need, finally, more stringent guidelines around malpractice to cap that. We haven't done enough so that doctors feel like they have more leeway in terms of providing the kinds of services and, yes, being held to task in terms of performance through bundled payments or accountable care organizations, but knowing that they aren't going to be penalized for not doing certain things, which is not addressed within the current law. So the bottom line is that before we take an aggressive step in the rhetoric of repealing the law, which could backfire, we need to be very careful in peeling back the layers of the law to understand the assumptions that have gone into funding, reappropriating those dollars into infrastructure, taking incremental steps in terms of improving the cost and quality of health care. This is going to be far more credible for any party today in the ultimate verdict of what will happen in the 2012 elections. Thank you.